At this time, can we ask Dr. Michael Biggs to come forward and make his presentation? Dr. Biggs?
Thank you. So I'm a sociologist at the University of Oxford. When students urged me to educate myself on transgender children, I read the literature on gender medicine. I was surprised by the poor quality of published research and very disturbed by the absence of data. There are huge gaps in that literature. One example, the world's largest pediatric gender clinic in London started research on puberty blockers in 2010. I discovered in 2018 that the results had been pressed, and I led a campaign to force the clinic to publish those results. I've now published my original research in journals like Archives of Sexual Behavior, Journal of Sex and Marital Therapy, Journal of Pediatric Endocrinology and Metabolism. As time is limited, I'm going to focus on one intervention for children experiencing gender dysphoria, and that is puberty suppression. Full documentation is available in my written submission to the board. So puberty blockers are a class of drugs, gonadotropin-releasing hormone agonists, such as Lupron. These GnRHa drugs stop the production of sex hormones. For males, these drugs achieve chemical castration. The drugs are licensed for a few medical conditions, such as prostate cancer in men and precocious puberty in children. They have never been licensed to treat gender dysphoria, not in the United States, not in the United Kingdom, nor any other country in the world. Puberty suppression is intended for juvenile transsexuals, and that is the phrase that is in the title of the article that was first published advocating their use, published in 1996. So keep that phrase in mind, juvenile transsexuals. GnRHa drugs can be administered from Tanner stage 2, which is the beginning of puberty. So in Britain, the youngest child to have been given this intervention was 9 years old. Advocates for puberty blockers claim that this is analogous to treating precocious puberty, for example, when a girl of 5 starts developing breasts. But that treatment for precocious puberty involves delaying a puberty that arrives abnormally early, so the child can undergo puberty at the normal age. By contrast, puberty suppression for gender dysphoria entails stopping normal puberty in order to prepare the child to take cross-sex hormones for the rest of their life. About 96% to 98% of children who start on puberty blockers continue to cross-sex hormones, usually around the age of 16 or their ages going down to 15 and 14 more recently. The only plausible scientific evidence favoring this intervention comes from a longitudinal study of an early cohort of 70 Dutch teenagers. De Vries et al. In 2014 published outcomes shortly after surgery when the patients were in their early 20s. Several psychological measures showed improvement, though these measures were taken for only a small subset of the patients, as few as 32 individuals. Gender dysphoria also appeared to decline, but the latter finding on gender dysphoria was likely an artifact of the measures of gender dysphoria being switched halfway through the research study. De Vries et al. Acknowledged that one patient was killed by necrotizing fasciitis during vaginoplasty. Out of 70 patients, that's a death rate exceeding 1%, remarkably high for a group of 12 teenagers. De Vries et al. Didn't mention that the death was actually a consequence of puberty suppression, as I'll explain in a moment. The Dutch researchers have recently followed up this patient cohort of 70 people, but they've not published the result. Well, the long outcomes are still unknown. The only attempt to replicate the study came from the gender clinic in London, which you might know as the Tavistock. They administered GnRHa drugs to 44 teenagers. Because the results of puberty suppression were not positive, the researchers decided not to publish them. I led a campaign to force them to publish, which took a couple of years in a high court decision in the Kira Bell case. Eventually, the clinic admitted that puberty suppression did not improve the psychological functioning of teenagers and did not reduce gender dysphoria. There is now a handful of American longitudinal studies, more recent, which are much worse in quality. Instead of replicating the methods pioneered by the Dutch and repeated by the British, each research team used a different set of psychological measures. They have tiny samples, They have high rates of attrition, which is never explained, and they use dubious statistical methods. So what then do we know about puberty blockers? Well, it's certainly true that early puberty suppression produces a closer resemblance to the opposite sex. Patients are more likely to pass superficially. However, this benefit must be weighed against several serious costs. There are some known costs. So for males, early puberty suppression makes subsequent genital surgery more risky and less satisfactory. The penis is so undeveloped that a normal vaginoplasty is usually impossible. And so instead, a portion of the patient's intestine has to be used. Leakage from the intestines after surgery is what killed the early Dutch patient at the age of 18. So that patient died as an indirect consequence of puberty suppression. Second, puberty suppression hinders the normal accumulation of bone mass. Up to 1/3 of teenagers who take GnRHa for 2 years end up with abnormally low bone density, which puts them at risk of osteoporosis in later life. Sweden drastically curtailed the use of puberty suppression because one of their patients developed severe osteoporosis at the age of 15 years old. More serious are the costs that are unknown. So we have fragmentary evidence, but all the evidence points that, in fact, early puberty suppression, followed by cross-sex hormones, prevents the development of normal sexual functioning. There will be no libido and no capacity to orgasm. What's astonishing is that clinicians who prescribe puberty blockers haven't bothered to study their effect on sexuality. So the lead Dutch researcher, De Vries, recently said that orgasm was an interesting but not so far studied question. And that's after her clinic had been using this intervention for 25 years. Finally, the most, serious unknown consequence is their effect on emotional and cognitive development, which is particularly important given, of course, we're concerned about the capacity to consent to further interventions. So a recent randomized controlled trial in mice showed that GnRHa drugs cause males to manifest high levels of stress, females to display increased anxiety and despair-like behavior. Again, it's remarkable that researchers have never studied the effect of puberty suppression on measures like, for example, IQ. Given the accumulating negative evidence and the continuing failure of clinicians to collect pertinent data, the English National Health Service just last week released a draft specification for gender services. In a complete reversal of existing policy, and I quote here, it will only commission GnRHa in the context of a formal research protocol. I recommend that the Florida Board of Medicine should adopt the same policy. Puberty suppression should be offered only in a proper randomized controlled trial. Obviously, it can't be blind, but then most randomized controlled trials are blind. But with a treatment group and a control group. Any trial must ensure that follow-up continues into adulthood and must guarantee to publish all clinical data. Thank you.
Does the board members have any questions for the doctor? Go ahead. Dave?
Dr. Biggs, thank you so much for being with us this morning. I have a question for you.
I'm finding it very difficult to hear your...
Can you hear me now? Is that better? Is that better? Dr. Biggs, can you hear me?
Sort of, yeah. Go ahead.
Could you please elaborate a little bit more on the last item that you mentioned, that last week the National Health Service issued a directive regarding a formal research protocol for the use of GnRH agonists? And could you tell us a little bit more about what that protocol involves?
No, I'm afraid I can't, because that's still under. There's no further details that's been released by the NHS.
Okay, because I was not aware of that, so this is breaking news. I'd be very curious to know what the details of that protocol may be.
Yes, I can send you the link. That wasn't in my documentation and my submission because it came so recently. I'll send you the link right away. But essentially, what this draft specification, I should emphasize, it's only a draft so far. But it just says that the emphasis has got to be on psychological care, helping children to reconcile with their own body and their own social circumstances, and that GnRHa will only be offered in the case of a clinical trial. So that's as much as we know.
Thank you.
Any other board members? Is Dr. Hunter?
I can clarify what the NHS guidance is because I have it with me. This is quoting from them. Because of the uncertainty surrounding the use of hormone treatments, NHS England is in the process of forming proposals for prospectively enrolling children and young people into formal research program with adequate follow-up into adulthood. NHS England will only commission GnRH analogs in the context of a formal research protocol. This research protocol, Dr. Diamond, and this addresses your question, this research protocol will set out eligibility criteria for participation. They're still creating their criteria in their research.
Thank you, Dr. Hunter.
Any other board members? If not, Dr. Biggs, thank you so much for taking the time off from your busy schedule and talking to us. I really appreciate that.